Welcome to the August 7th, 2025 Talk with a Doc. I hope all of you are having a good summer. And we're joined by Dr. Timothy Leichliter, Movement Disorders Specialist Neurologist from Allegheny Health Network. I heard he's on call this week. And please take it away, Dr. Leichliter.
I am. So if somebody important calls, I may have to answer it, but I'm going to do my best. We'll see how it goes. Well, welcome to the party, everybody. We didn't have one last month, so it's been 2 months. All right. Well, time flies, man. The summer's passing quickly. I am Dr. Leichliter. Welcome to the party. If you've been here before, you know the drill. If you've never been here before, welcome to the party. This is a question and answer session for you guys. So if you have questions or concerns or things you really want to know or want answered and you want my opinion on, type them in the chat box. I do have some email questions that I'll start with. The usual caveats I always give are this is not a great individualized therapy program. This is a good general program. And so if you ask me, I'm on this, and this medicine, what do you think I should do next? I'm going to say you should talk to your doctor about that. This is also my opinion. Now I have the platform, so you're stuck listening to my opinions, but they're my opinions nonetheless. I like to think my opinions are based in as much scientific evidence as I can muster, but that doesn't always happen. Sometimes I do make stuff up. While I think a lot of us in movement disorders do things very similarly, we definitely don't all do the exact same thing. And so if you go to somebody different, you may get a different opinion. All I can give you is my opinion. Take that for what it's worth. The end. So welcome back, everybody. Let me get started here. So one of the first question that I got was, so in a recent article, about 25% of patients with Parkinson's disease were thought to be genetic, some kind of genetic mutation. And one of the most common forms of genetic mutations is something called LRRK2 or LRRK2. And they really just wanted my comment on that. And so LRRK2 is one of a whole bunch of different genes that are known mutations that we think leads to Parkinson's disease. And of them, I think actually LRRK2 is the most interesting, which I'll come to in 1 second. Glucocerebrosidase, which is GBA1, is probably the most common. But then LRRK2 is probably second. Then there's PANK1 and 2. PANK, there's a whole bunch of different genes. But the logic is that with what we know, and again, I'll come to that in a second, about 25% of Parkinson's disease is directly due to one of these underlying genetic mutations. I say that we know because if you would have asked me 10 years ago, I would have said maybe 5-10% of people with Parkinson's disease are genetic. Then it went up to 15%. Now we're up to 20 to 25%. But guess what? If you ask me again in 10 years, that number's probably going to go higher because the more genes we learn about, the more genetic testing we do, the more available genetic testing becomes, but because traditionally genetic testing has been ridiculously expensive and hard to get, but it's becoming more cost effective. And B, the better genetic testing becomes, the more genes we find. And so the more genes we find, the higher that number or percent goes up in terms of how much we think is directly genetic. Now, obviously, if 25% is genetic, that means 75% isn't. And so the large majority of patients with Parkinson's disease do not have, as far as we know, an underlying gene mutation that explains their symptoms. So we think there is still a lot of genetic underpinning, environmental triggers, factors we haven't quite figured out that ultimately leads up to Parkinsonism or Parkinson symptoms in any given person. Why I think LRRK2 is interesting is we've learned a lot about this gene, and it works in a whole bunch of different areas of nerve function, cell function, both in terms of, vesicular trafficking, so making dopamine travel from where it needs to go, mitochondrial function, inflammation. So it hits a lot of the things that we think of in terms of the triggers of Parkinson's disease. But why I think that this leucine-rich repeat kinase, LRRK2, is interesting is about half of people with LRRK2 who have Parkinsonism do not have Lewy bodies when we do pathology. And that's extremely interesting because traditionally we think of Parkinson's disease as a Lewy body disease formation problem, much like we think of Lewy body disease, where you get these clusters of alpha synuclein that form these clusters in these balls. And you can see this on pathology slides after autopsy. And we've always thought about this as being one of the potential causes, or at least a big player in the formation of Parkinson's disease. And it turns out in this specific genetic variant, they don't always have that. And so we're still, as a community, trying to wrap our head around that, especially because there is such talk in my world about reclassifying or describing how to diagnose Parkinson's disease. There's a lot of talk in the movement disorder world that we should really be using genetics to label or diagnose Parkinson's disease, which classically has been a symptom diagnosis. And it's things like this that are interesting, because what do we do with that information? Clearly, everybody does not have the same thing, but also 75% of Parkinson's disease doesn't have a genetic underpinning as far as we know. And so that would reclassify a lot of different people. So this is why there's a lot of battles. And again, as much as you can get battles with nerds of neurology, we don't actually battle. We don't fight very much. We're kind of weak. But you get the idea. In my meetings, this is what we talk about. And so I think this is going to be interesting. This is going to be something that we pay attention to. The genetics of Parkinson's disease is a very hot topic in the world that we live in, because ultimately we know that Parkinson's disease is really a syndrome. Again, Parkinson's disease is a collection of symptoms. If you have tremors and stiffness and slowness of movement and balance problems in the right setting and the right progression and the right response to medicine, that's how you get the diagnosis. Everybody who has those symptoms in that progression and that diagnosis does not have the same thing. There are different genetic causes, there are different environmental triggers, there are different circumstances and situations that really add up to that syndrome that we call Parkinson's disease. And so I think that's an interesting thing that's more to come. Ultimately, it would be ideal if we were able to use genetics to really pinpoint this is a specific treatment for a specific genetic or environmental problem. That's called precision medicine. That's the gold standard in the ideal. We're just not there yet. But every time we learn more and more about these genes and these genetic conditions, and we find more things, it leads us to that ultimate goal of really being able to better tell you what specifically you have, and then better being able to target a treatment tailored specifically for you. That's a long-winded answer of LRRK2 and the genetics in Parkinson's disease, but just know this is actually a really big topic in the movement disorder community and world, because of how it could potentially affect treatment options for people with Parkinson's disease. That's my thoughts and comment on that, which dovetails to question number 2, which is what are my thoughts on genetic testing of Parkinson's disease? Which is, again, it's hard to get. Insurances still don't really like to cover genetic testing. And their logic or their argument is that it doesn't currently change treatment management, which they're right. I would not treat a GBA versus a LRRK2 versus a PARK genetic mutation any different. The medicines are still the same. The therapy is still the same. My harping on you about exercise is still the same. And so that's their argument for not using it. But there's a study going on called the PD Generation Trial, which has multiple sites around the country run through, I think, the Michael J. Fox Foundation. There's a lot of kind of direct to consumer, 23andMe-esque type of genetic testing. Again, 23andMe, I'm pretty sure went bankrupt, so I wouldn't go with that one, but you're starting to see more of that come around. So we are getting more and more access to genetic testing. And again, I do think ultimately it will be more useful. We just haven't gotten there yet. So again, if you're interested in genetics, you're more than welcome to hop on the trial or get involved. Again, doesn't necessarily help us do anything for you at the moment, but the future plans or goals, I think, really do. The next two are actually things I hadn't heard about. So what are your thoughts on hydrogen therapy for Parkinson's disease? And this actually took me down a wormhole this morning when I was reading about H2 water and hydrogen water pitchers. I went far in this one because this was interesting to me. And so the long story short is hydrogen therapy is exactly what it sounds like. So using hydrogen gas as a potential treatment option. And there's different ways you can get it into you. They can squeeze more hydrogen into water by diffusing it or by electrolysis. You can inhale certain percentages of gases of hydrogen. And so these are what we're talking about. And I went to look this up because I was like, there's no way there's evidence to suggest that hydrogen, but there actually is. I was mistaken. There was a study, there was a couple of studies. One was done back in 2013 that suggested there was a very small, but potentially statistically significant difference in UPDRS, which is the United Parkinson's Disease Rating Scale, in this small study that they did. And it's a lot of this data comes out of Japan. They did a small study looking at people who were drinking this hydrogenated water versus people who didn't. And it was a very small number of benefit in UPDRS, but it was statistically different than the regular water. And so that prompted a few more tests, which didn't pan out. And so there's been kind of mixed results in terms of these trials. The idea is that hydrogen is potentially a really good antioxidant or a free radical scavenger or an anti-inflammatory, all of which, again, we think is in the underlying causes or triggerings of Parkinson's disease. And so you can imagine that maybe it would have some benefit, some use. It's really hard to study these kind of things. Any of these alternative medicines or complementary medicine approaches are really hard to do good gold standard randomized controlled double-blinded trials. And so getting good evidence is difficult. It also can get a little bit expensive. And if you're dealing with actually inhaled hydrogen, if you have the wrong percentage, it can actually literally be explosive. And so I don't know that I would necessarily recommend it at the moment, but if you were interested in looking into it, I wouldn't be against it as long as it's cost effective for you. It does seem like there's some scientific rationale, and it does seem like it even has some, albeit small, but potentially positive trials in its favor. Again, not enough for quality evidence to suggest that yes, everybody with Parkinson's disease should be doing hydrogen therapy, but enough that if you were interested in doing it, I wouldn't be against it. And then the other thing that I learned about, or the next question, was about an app. So it's called Parky for Parkinson's. And I guess it's through Apple or iPhones, which of course I don't have. So maybe that's why I didn't know about it. I'm a Galaxy user. And we always get things much, much later and after the Apple people do. They're always way ahead of the game. But so there's a portal that now I have signed up for, so I could potentially create new prescriptions for. That apparently there's an app you can get on your iPhone, and I don't know if it uses an iWatch or an Apple Watch too, or you just have to have an iPhone. There's not a lot of information on their website, but it does look like it tracks a lot of things. It looks like it tracks maybe activity or walking. Maybe it tracks tremor if you have a wearable device. I mean, it seems like there's areas you can put medication use in or downtime in, or you can log how you're feeling. And this is actually similar to something that I trialed however long ago I was in Bellevue that I can't remember because all of my time runs together. I feel like that was at least 5 years ago, 6 years ago. There was a company called Global Kinetics, I think, that let me trial a wearable device. And people would wear it for a week, I think, and then I would get a printout sent to me with information. And usually it was on and off and shaky versus not shaky and correlations with medicines. And I didn't find it all that useful, but I did find it useful in terms of just looking at some raw data and seeing if maybe there was enough downtime or times of day where we could use that information that maybe I could make medication adjustments. And I think this is actually part of what I'm going to call the wave of the future, which is wearable devices and technology. Because I really do think that technology, regardless of whether you or I like it or not, which I don't always like technology, I'm a little bit old school in that fashion, is not going anywhere. You're only going to see more and more use of technology, wearable devices, measuring tools, at home things used in not only diagnosis, but treatment and management of a lot of conditions. And Parkinson's disease is no different. The other thing you're going to see is AI. Artificial intelligence is going to be a big part of this because they can sort through data and sift through things much, much quicker and more accurate than even I can do or doctors can do. And so the problem that I foresee with this until we start partnering it with AI is that this could generate a tremendous amount of data and information, more so that I would ever be able to actually sort through or look through on any given day. And so I think where this is going to be useful is yes, the data is useful, but partnering it with some sort of artificial intelligence or some sort of filtering device that would go through this data and really give us the high points or what's important out of it. Something that could scan through you wearing a watch or having your phone on you 24/7 for a day, a week, a month, a year, and then take all that information and distill it into this is the end result. Because there's not going to be a way that me or I think any counterpart of me is going to be able to sort through that much information to be able to make heads and tails of it. I really do think that this is useful, and I am now signed up for it in case anybody is interested, if you're my patient. But at the end of the day, I think this is going to be useful when we have ways to manipulate or sort through all of this information that this could potentially create to a usable format. So I thought that was interesting, and I don't know that this is available outside of the Apple or iPhone bubble. Um, it seems like it was specifically for iPhones, but again, usually when things are iPhone, they eventually trickle down to all the other users. And again, I do think this highlights the fact that technology, wearable devices, at home monitoring, and direct to you guys kind of devices are going to be part of the future of how we manage and take care of not just Parkinson's disease, but a lot of things. I really do think that that's going to be important in the future. But I thought that was interesting nonetheless. And then the next two things were both similar article. They might have even been the same company or the same group, but they were basically asking about injectable levodopa. So there's this group in I think Australia who's working on a kind of like a depot shot that lasts about a week of levodopa. Um, and I think both of these were about that type of a thing. And so just to backtrack a little bit, one of the biggest problems that we've run to in Parkinson's disease is levodopa. It's not a very stable compound. We hadn't really come up with better ways to get it into you outside of taking a pill. Duopa's been around for a long time, but it comes with its issues. You have to have a tube in place. It's directly infused into the small intestines. But realistically, it's cumbersome to use and difficult. Up until the end of last year, where Vyalev got approved. So Vyalev is a subcutaneous infusion of a version of levodopa that's worn 24/7. Again, I've used it a couple of times, but this is not about my experience because I haven't had enough experience with it yet to really make an opinion. But what I think it leads to is potentially other things like injections or other ways to get levodopa into you without having to take pills. And this is not only going to be helpful, I think, for patients on a day-to-day basis, particularly patients who are taking pills very, very frequently, or who have tremendous side effects to taking the pills, which could still come with the injections as well, but particularly people who are in the hospital, people who are confused or aren't taking pills or can't take pills or are having trouble getting pills in. These are other things that I think have been long time coming, which I think we're heading towards now. And so I thought those were really interesting. Again, I don't have my hands on any injections yet or depot shots yet. And I think they still have to be in bigger trials and show that they do what they're supposed to do, which is be stable and release at certain intervals. And so I think we're still a little bit of ways away from getting stuff like that. But I do think the fact that now we have a subcutaneous infusion of levodopa that really opens itself to other injectables or other types of ways to get it into you without having to take pills, which I think would be really helpful. I think that was all I wanted to say about that. And then the last one from this email was, what are your thoughts on stem cell therapy for Parkinson's and gene therapy for Parkinson's? And of course, I have thoughts on everything. I do think stem cell therapy has a role in the future. Again, I've always thought that when you're dealing with neurodegeneration, meaning if you look at brain cells, they are lost. And this isn't just true for Parkinson's disease, this is true for Alzheimer's disease, Lewy body disease, any of these so quote unquote neurodegenerative processes. If the end result is that you have lost brain cells, then it makes a whole lot of sense that if we could regrow brain cells, that should correct the problem. Now, again, that's a big if because we're not there yet, but that's where I think stem cells come into play. Stem cells are really just an overall term for cells that we can make turn into other things. And so, again, if we can take a pluripotent cell or a cell that can turn into a whole bunch of different things, from a variety of sources, which I'm not the expert on, and we can get them to grow into dopamine producing cells, and we could get them to replace the cells that are lost, then that makes a whole lot of sense. The hard part is doing that. Again, it's taken a lot of smart people, and to this point, I think about 30 years, 30 plus years of work in the stem cell realm to get to where we're at now, which is still not ready for prime time, but we're getting closer. So there were a couple of publications recently in mouse model where they're having some success, and there was one person who had success in Harvard, but that came with a lot of caveats. And so I do think stem cells are progressing in the right direction. We're just not ready yet. But I have to assume that if, again, loss of neurons or loss of brain cells is the underlying problem, then if we could figure out a way to regrow, reattach, resprout, reconnect brain cells, that would be a tremendous asset in in treatment strategy. Again, I am always interested in seeing how this goes because I really do think it plays a role in the future. I'm just not sure when the future comes. Gene therapy is a little bit different. So Dr. Van Laar, who is our president at the Parkinson's Foundation, currently is in this field. She did a great job of talking about it at the last conference. It is very complicated. So if you didn't understand everything she says, don't worry, neither do I. She is infinitely smarter than I am in terms of understanding how this stuff works. But again, it's still in research. So that's something to keep in mind. The idea is that we can directly infuse different genes or different vectors into the brain to reset some of the degeneration or degradation that's happened. And that's what they're trying to show. And they're learning different techniques. They're finding better ways to get these vectors in. They're finding better ways to cover the areas of the brain that need to be covered so that we get the best results. And so far, their data has been promising and they're optimistic about it, but they're just moving into kind of stage 2 trials now. And so the jury is still out. Again, it's still research. It's still interesting, and I'm still interested in seeing what the end result is. But again, I like to wait and see when the results actually come out. So more to come on that, but I do think it is promising. It's just a matter of waiting to get to the results to really see how promising it can be. And then I had one more email with just a couple of questions on it. So one was, am I familiar with a new trial that will examine the relationship between exercise and sleep in patients with Parkinson's disease? And the first time I read that, I was like, wait a second, we already proved that. So there was actually a trial that came out within the past couple of years in my journal that proved that exercise definitively helps sleep architecture, and help people feeling less fatigued. That study has already been published. But then I went and looked, and there's actually one, two, three, four different trials right now looking at different aspects of sleep that exercise could potentially improve. So one is looking at different exercises on sleep quality. Another one's looking at multiple types of exercise and how it improves sleep quality, motor function, cognition, quality of life. Another one's looking at just high intensity exercise on objective sleep measures, daytime sleepiness, mobility, and brain health. And then the Sparks 3 trial is the exercise trial that's been going on for a little while that isn't necessarily looking specifically at sleep, but looking at overall Parkinson's disease, but does have some sleep indices in it. And so there's actually four different trials that are going on right now, all examining the benefits of exercise, particularly aimed at sleep. But I don't need a study to tell. I like studies, and believe me, I like evidence. But at the end of the day, I can tell you through my experience that exercise helps you sleep better. Plain and simple. That's been my experience for the past 10 years. Exercise improves everything. It's my ultimate favorite topic. Everybody knows that. If you've listened to anything that I've talked about, exercise is a big part of it. But I definitely think that exercise does have positive impacts on sleep quality, and how you feel after you wake up. And so I highly recommend exercise to everybody, whether you have Parkinson's disease or not, but definitely if you have Parkinson's disease, it's super important. And then the last one actually made me think, oh, we're drinking orange spice tea again, which I'm pretty sure is the same one I drank last time, but it's what I had in my desk. So the last one actually made me think. So the last one was, are there any medicines that you have found that are used for treating Parkinson's symptoms that have contributed to memory and cognitive issues? And once they are discontinued, those issues have improved. And so what that's asking is, have I caused cognitive and memory issues as a side effect of the things I use to treat medicines? And of course, the answer is yes. I have caused just about a side effect. If you can name a side effect, I have probably caused it with something in somebody. The ones that we typically think about that lead to cognitive and memory problems, the number one that stands out is Klonopin. Now, I use Klonopin, clonazepam not infrequently. It is a great sleep medicine that helps calm down REM behavior sleep disorder, which is acting out dreams, yelling, kicking, fighting. It's also a good anti-anxiety medicine, but it is known to cause, with prolonged use, memory problems and cognitive problems. The same thing is true about the anticholinergics, which I don't use a whole lot of, but it is a class of medicine that could be used in Parkinsonism. This would be benztropine and trihexyphenidyl. These were actually the medicines that we used prior to the invention of carbidopa-levodopa, so that tells you how long they've been around. They are really good medicines for some tremors and some stiffness, but they come with a hefty price tag of causing cognitive problems, memory problems, balance problems. And so this is why I don't use them all that much. But even in cases of carbidopa, levodopa, pramipexole, amantadine, I have had patients come back and say, you know what? I don't think I'm thinking right on that medicine. I can't remember things. My cognition is worse. For just about every medicine you can think of, I have had patients come back and tell me about it. And a lot of times, yes, that is reversible. So we take them off the medicine, their side effect gets better, but not always. And that's something we have to keep in mind. Again, there's definitely ones that are more likely to do it than others, and I would say clonazepam, and then trihexyphenidyl, benztropine are probably the ones that do it the most. But you can get those as side effects to just about everything. And if you are noticing it, particularly if it's in and around the time that we've adjusted medicines, added medicines, or increased medicines, well, then maybe we do have to backtrack and see if that gets better. But this is where, again, communication is so important. I want one of my medical students or residents to do a study to suggest just how often in between office visits we change medications. It's got to be astronomical because I can't see patients as frequently as I would like to, the scheduling, so on and so forth. Communication becomes so important and adjustments via communication become so important. And so this is another area where that communication is really important. If you're noticing a side effect, particularly after a change, even if it is something like cognition, which you're like, well, is it just because I'm getting older and I can't remember as much as I used to, which I hear about all the time? If you're noticing a change, particularly in and around the time of a medication adjustment, then that's something we need to know so we can figure out if it's something we can just watch and say, well, let's give it more time and let's see how it goes, or no, this is a problem, we should really do something about it. So the short answer to your question is yes, just about every medicine I've ever used can in some instances cause those problems. And we just have to figure out what it is, how do we adjust for it, and what can we do better? Sometimes it does get better, sometimes it doesn't, and that's a trickier situation. All right. That was all the email questions I had. For 2 months, Casey, honestly, not as many as I was expecting. So I'll take it. All right. Have I heard about a skin patch for sustained release Cinemet? Any experience or opinion about this to help smooth out the highs and lows? So yes and no. So they've been working on, there's a company that makes these patches that I can't remember offhand, who's been working on a levodopa patch for a really long time. It was never formalized, finalized, available, at least not in this country. And so they've never really been successful at putting levodopa into a patch. And that really comes back to the same problem they had trying to come up with a liquid formulation, which is it's very acidic. And so in order to stabilize levodopa outside of a pill, it has to be in a very acidic formulation. And obviously that's very irritating through a injection or through a patch. I wouldn't be surprised if they get closer to it now that we have some more stable formulations of it. But the short answer is I've never been able to get my hands on a Cinemet patch. We have a new pro patch, which is rotigotine, which is a dopamine agonist. So this is the same class of medicine as, say, Mirapex or Requip that comes in a patch, and I love it. And again, coming back to the fact that 90% plus of the medicines that I have to treat people with Parkinson's disease are pills. And pills are by no means ideal for everybody. It would be really nice to have alternative routes of administration for a variety of reasons. So I do like the patch. And one of the reasons why I like the patch is it's steady state. So it's not taking pills. It's not this up and down business. It's fairly consistent. And the other reason that I like the patch is, again, one hard problem that I run into very, very commonly is that very rarely do the pills last overnight. our pills, and this is true for even the extended release versions, the XL versions, all the versions, the newer versions, the older versions, they just don't last 10 hours or 12 hours or even 8 hours that people were sleeping. And so a lot of times people wake up in the middle of the night because guess what? If your pills are wearing off every 3.5 to 4 hours during the day, 3.5 to 4 hours after you go to bed or take your last pill, they're probably wearing off and you're going to wake up and it's going to make it hard to go back to sleep. Or even more than that, when people wake up in the morning and they haven't taken pills since 8 o'clock, 9 o'clock, 10 o'clock at night, they really struggle to get going in the morning. And so if we had longer lasting versions, that could really help solve some of those problems. And that is a couple of the reasons where you'll see me use the new Pro patch, because again, that steady state of medicine through the patch, and you wear the patch all day and all night. And so again, not the only solution for that problem, but one of the solutions. And so the short answer is I have yet to get my hands on an actual Cinemet patch, although that's been in process for a really long time. But I do like patches, and as soon as I can get one, I'd be more than happy to try it. How does apomorphine work, and does it lead to obsessions? That's a great question. So apomorphine is a dopamine agonist. And so what that means is it activates dopamine receptors directly. This is different than carbidopa levodopa. Levodopa is the precursor to dopamine, so your brain absorbs the levodopa and then converts it into actual dopamine. Medicines like pramipexole, which is Mirapex, ropinirole, which is Requip, rotigotine, which is Nupro, and apomorphine, which is the old Apoquin, the old, I can never remember the name of the damn, excuse me, the
And
thin
Moby.
film. Thank you. I love it. My team is on here to remind me of the name Kinmobi because I can never remember it, which was the thin film that we had for a very short amount of time. And now the newest version of Napco is another dopamine agonist. And so these medicines all activate dopamine receptors directly. They're not actually increasing dopamine itself. They're going directly and activating these receptors to have them do what they're supposed to do. The problem with this class of medicine, which can also happen with the other medicines, but is predominantly with this class of medicine, is the impulse control problems. So they don't necessarily activate dopamine receptors in any one area. They do it in a diffuse fashion. And dopamine is also the reward chemical. And so when you activate those medicines, you start getting into motivation and in particular impulse control problems. This is predominantly, and I would argue, I don't know if this is statistic, but arguably most seen in Mirapex, and that's purely because Mirapex is the most potent. And so it can happen with all of the others. It can actually happen with carbidopa, levodopa as well, but you will read about it, you will hear about it with this class of medicine. I think personally it is statistically less with Apoquin. I don't know if I'm making that up or if that is statistically true, but at the end of the day, I have to assume that just because it works in the same fashion, it can also come with the same risk. Interestingly enough, we just got our hands on the subcutaneous infusion of apomorphine, which is a NAPCO. It's one of the two pumps that I'm talking about when I'm talking about the newer versions or newer routes of administration that I think will be very interesting, but I have not used it in very many patients, and so my opinion is still out. We think, again, it leads to these obsessive compulsive behaviors or impulse control problems because it's activating really your reward pathways or your limbic pathways, which control fight or flight, sex, eating, gambling, all the things that make people feel good or happy, are run through this area of the brain. And this is activated with these dopamine receptor activators. And so we think that's how it works, although we haven't necessarily worked that out perfectly, but that's something to keep in mind when you're on some of these medicines. Again, it is not restricted to this class of medicine, but this class of medicine is where it is described the most. Have I had any patients that feel breathless and or feeling like they're being choked right after taking carbidopa levodopa? Yes. So carbidopa levodopa has side effects as well. They do not have a side effect-free medicine. Just doesn't exist. And one of the main side effects of carbidopa levodopa is something called dyskinesias. This is probably where I see this problem the most, although it doesn't have to be related, but it usually is. And so much like you can get squirmy movements, and I describe a dyskinesia as if you've ever seen Michael J. Fox on TV, whenever he was talking to the government, he would constantly be moving. He could not sit still. That is a dyskinesia. That is a side effect of the medicine or the routes of administration of medicines that we're giving you. That is a side effect of of what we're doing to you by giving you pills that give you a burst of dopamine and then wear off. That is actually, we think, probably more due to receptor changes and hypersensitivity to medicine than anything. But regardless, it's a side effect of the medication. Interestingly enough, you can get that same type of extra movement in the diaphragm or in the swallowing muscles, and it can give you a shortness of breath feeling. I've had a lot of people tell me that they feel like they're short of breath. They can't catch their breath, but they're actually breathing okay. If you check their oxygen levels, they never go down. And the same thing is true about coughing or other types of vocalizations or kind of sensations or movements. Usually when I'm dealing with that, especially if it's that time locked with taking the carbidopa levodopa, it's a dyskinesia, or if nothing else, at least a side effect of the medicine. Sometimes you can get away with decreasing the medicine. Sometimes you can get away with switching to a longer lasting version of the medicine, a controlled release version, or if you're on regular carbidopa, levodopa, or Rytaria or Crexont, which are the newer versions of it. Sometimes we do add things like amantadine or gocovri, which is specifically approved for the dyskinesias and Parkinson's disease. And so at the end of the day, there are a lot of ways we can try working on this, but this is where, again, communication comes in handy. If you're able to pay attention and pinpoint that, hey, every time I take my pill, this is what happens, that gives us a tremendous amount of information to allow us to adjust things, change things, switch things, take you off of things to really try to solve that problem. Obviously, it's not that easy. And not everybody is able to pinpoint specific triggers, timings, correlations, nothing that's always that obvious, but if you can, it really does help. But yes, I have seen that, and I do wonder if it's either a direct side effect of the medicine or a more of a dyskinesia. Have I seen the ParkyBot.com AI site for Parkinson's? I haven't seen it, but I just pulled it up now. I am ParkyBot, an AI researcher for PD. Ask me anything about PD, but remember, I am an AI and I can make mistakes. I like that. I will play with this a little bit and remind me next time, ask me about it. I will let you know. I don't know if it uses the Chat GPT database. There is actually, and again, coming back to AI is everywhere. I use it in my office now. I let my phone listen to our conversation and it prints out a note. So if you've ever seen my notes, you'll actually see they don't look like they used to. And to some extent, they may not be quite as good as they used to, but they'd save me a lot of time because it artificially, intelligently copies down everything that we talk about in a reasonable fashion. Doctors nowadays are using something called open evidence. So open evidence is through the New England Journal of Medicine AI function where you can ask medical questions and it searches databases of Mayo Clinic and NYU and a lot of these high professional societies or academic centers and will basically summarize all of the evidence in the internet somewhere and give you specific answers. Again, you're going to see more and more of this. I don't know if that's also Chat GPT or if that's a different AI box database, but at the end of the day, you're going to see more and more of this. I'll play with Parkabot until next time and I'll let you know what I think. But no, I hadn't heard of that, nor have I played with it yet. Does levodopa become less effective the longer you were on it? And if so, what is the time frame? Yes, maybe, we think so, and unknown is really the answer to all of those questions. Yes, the benefits of levodopa become less over time. Now, is that because that you become used to the medicine becomes less effective, or the disease progresses, or some combination of all of the above? Yes. Time frame is variable. And this is very individualized. I don't believe there are specific timeframes. There are studies to suggest, and this comes back to the staging systems of Parkinson's disease as well, that there are averages of timeframes between 1, 2, 3, 4, 5, averages in timeframes of start of levodopa to dyskinesias to motor fluctuation, so on and so forth. But take it with a grain of salt because everybody is very individualized. And even though there are averages, I really don't believe averages when it comes to individual people. And so I don't like to give you a time frame and say, yes, statistically, it is going to start wearing off in blah, blah, blah years. I wait and see how you do because everybody really is a little bit different. And I don't think it makes sense to tell you this is the number and then you focus and worry about the number. And it turns out that wasn't the number for you at all. And so I don't personally like to use that data in individual patients. Yes, there are statistics on these things. Yes, there are averages on these things. Yes, there are papers on these things. But realistically, in day-to-day practice, I don't find them to be all that helpful. What I would focus on from you is kind of how you're doing. Use yourself as your own guide. How did you do over the past month, 6 month, year, 5 years? You can sort of extrapolate that to the next month, 6 month, 5 year, 5 years. It's not a straight line, and there are a lot of variables there too. But I would rather you use yourself as your own indicator as opposed to compare to what a study suggested somewhere was the normal values. Yes, it does become less effective over time. And yes, we make up for that by increasing the dose, moving them closer together, and adding things to them, or potentially more aggressive things like ultrasound or DBS or infusions or things like that. But I don't think that I can necessarily say this is the time frame, or I could, but I just don't want to. I had an in-home bone density test. That is very high tech. I actually hadn't heard of that being done in home, but bone density is important in my patients because, again, unfortunately, falling is a very common thing. And so we cannot ignore osteopenia and osteoporosis. So I like that you got that done, and hopefully we can use that. Humanity. That's a good question. I didn't know who would do stuff like that. We will have a webinar on gene therapy on 9/25 at noon. Okay, well, that sounds good. Is that, again, Dr. Van Laar?
That's not Dr. Van Laar. It's another doctor through the same company.
Oh,
I
okay.
actually included the link for that webinar registration below.
Great. Can Klonopin also cause low blood pressure problems? It probably can. I would argue the vast majority of medicines that we use for Parkinson's disease of any type do tend to cause lower blood pressure. Klonopin, not as much as maybe levodopa does, because levodopa definitely does, but I'm sure it can. And even if it calms down anxiety, that in and of itself is going to lower blood pressure as well. But I also think there's probably some evidence that it can directly lower blood pressure, as can many of the medicines that we use. And don't forget about Step Forward on September 27th. I do have to talk to you about that one, Casey, but that's an offline topic.
Okay.
That happens to be the same day as the event up in Erie, which I have already
Oh, okay.
promised to go talk at. So I'm going to see if I
Right.
can make both. But yeah, we can talk about that.
Okay.
Erie's far.
Right.
How does taking dopamine affect your heart? Can it cause irregular heart rates? I mean, it's a great question. So believe it or not, they use infusions of dopamine for cardiac diseases in terms of increasing your heart rate, things like that, boosting, heart and cardiac effect. There has been looks at Parkinson's disease effects on the heart as well. In fact, an old test they used to do was actually a heart scan to see if to try to determine if somebody had Parkinson's disease, because we know the autonomic system is also affected. And I do think there is some effect of dopamine, even the pills that we give you, on the heart. Um, I don't know if it can cause a regular heart rate. I mean, it may very well be able to. I cannot think of a single patient that I have had come back and say, you put me on levodopa and I had a fib, or I went into an irregular heart rhythm, or I went to my cardiologist and they told me that was related to my Parkinson's disease medicines. I have not run into that in my experience. I haven't looked it up to see if there's any reports of it. I wouldn't be surprised if there are, because again, dopamine can have that effect on your cardiovascular system and your autonomic nervous system. Um, and so I don't know exactly how much it can impact that, or how often it can cause irregular heart rates, but I wouldn't be surprised if it's reported and if there is something to that. Does Parkinson's disease impact the immune system? Yep, sure does. In fact, I feel like this was a question that I blew off a couple times ago because I didn't know the answer. And so then I went and looked it up, and it turns out it can. And they've actually studied this. So people with Parkinson's disease do tend to have a weaker immune system, meaning that they are more likely or prone to get the flu. I don't know that I saw anything about COVID, but I did see the flu and just general colds or infections, which is why I think it's personally important to make sure you're up to date on all your vaccines. I am not the best person to figure out which vaccines you're supposed to get. There's definitely a schedule. Your primary care doctor probably knows that better than I do. Um, but I definitely think it's worth keeping up to date on all the vaccines that they recommend. I don't know what they're recommending about COVID these days. I can't even remember how many vaccines I've had for COVID or when I'm due to get another one. I'm not sure who they're recommending the shingles vaccine for. Believe me, there are recommendations for all of these things that primary care doctors are much better at than I am. But realistically, whatever they're recommending, I'm recommending, because there is some evidence to suggest that your immune system can be compromised with the diagnosis of Parkinson's disease. I can't think of offhand very many people that have really developed significant amounts of infections after their diagnosis, but I do see a lot of people who come in with urinary tract infections. Now, again, is that because your bladder and urinary issues are impacted in Parkinson's disease and you get backup and that leads to infection? Or does it have something to do with the immune system and the response in Parkinson's disease? I'm not entirely sure. But at the end of the day, I do think there is a correlation there. I do think Parkinson's disease has a direct impact on the immune system. I did look at a couple of studies that suggested that. I feel like a few months ago when somebody asked this question and I didn't know the answer. And so I think at the end of the day, trying to stay as healthy as you can, doing whatever your primary care doctor recommends from a vaccine standpoint. But again, getting out, being active, exercise, eating right, sleeping enough, eating enough, drinking enough, all general healthy things to keep you in as good a shape as possible, hopefully as healthy as possible, is probably the best way to avoid the cold, the flu, again, things that are everywhere all the time. Washing your hands a lot, all kind of normal things, especially in flu season, cold season. Stay, and not that I want you to stay away from your grandkids by any means. Go enjoy your grandkids, but just know that kids are a cesspool of disease. Mine are, at least. And so you just have to be careful, washing your hands regularly, so on and so forth, because I do think you will be more prone to infection. And if you have had an infection, or if you know somebody who's had an infection, you know just how much that wreaks havoc in anybody who is my patient. It oftentimes lands you in the hospital because hallucinations and confusion and agitation, altered mental status become a real issue. Mobility becomes a real issue, just triggered by something that stresses the system, such as infection. And so, since again, you are more prone to infection, it is really important that we do our best, because believe me, ending up in the hospital is not a good plan if it can be avoided. Have I ever advised anyone to temporarily lower their carbidopa levodopa to increase its effectiveness? No, and here's why. So we used to, believe it or not, they used to give people drug holidays. This was before my time. They used to, this was mainly back when levodopa was the only drug we had, or one of the few drugs available. When that was one of the only drugs we had, your only choice was to take more of it. And so we would ramp people up significantly high on carbidopa levodopa to the point where we were definitively causing hallucinations and dyskinesias and motor fluctuations and so on and so forth. And so back in the day, and I don't know when this was, so I've been practicing for 11 years. I was a fellow for one, I was a resident for four. So we're talking at least before 15 years ago. They would admit people into the hospital. They would take them off of their medicines, all of them completely, give them a little bit of a holiday. I don't know if it was a day, a week, see, whatever. And then they put them back on at a lower dose. And theoretically, they were hoping to accomplish just that, which is a reset. We don't do that for a reason. It's because it didn't work, and it only made people significantly worse and caused significant morbidity. And so at the end of the day, it turns out drug holidays were not effective, and they did not solve that problem, which is part of the reason why people think that it's more disease progression than it is a side effect of the medicine. I still think it's probably a combination of everything, but because that didn't work, I no longer do that. I never did that, but we as a group, I don't think ever really do that. I don't think it's as much a problem that, well, okay, if I just give you less medicine, that will reset the receptors and allow it to work better. I don't think it's that cut and dry or that crystal clear. And I think the problems that you cause by doing that probably are worse than anything you might solve. So that's why I don't do it. And I don't know that anybody's done that I've seen practice. If you take extra doses of carbidopa levodopa as a rescue from a freeze, can you go back to taking less? Sure, absolutely. The one thing I like to tell my patients is there's not a lot of rules. We're making it up as we go. I mean, I don't want to be the bearer of bad news, but we're literally making it up as we go. And we're making it up as we go because we know general rules of thumb. We know general guidelines. I can tell you about every single medicine known to man. I can tell you about what they're supposed to do. I can tell you about general rules of thumb, but I cannot tell you what's going to happen when you take it. There's only one way to find that out, and that's by taking it and seeing what happens. And so there's a lot of trial and error here. There is a lot of, well, let's do this and see what happens. And so, yes, I have a lot of patients. And believe me, I am not suggesting that you should tinker with your own medicines outside of what your doctor tells you should do. I am suggesting that you should have these conversations with whoever it is that does take care of you, because there are some parameters we can give. I oftentimes give my patients leeway to take an extra pill, take an extra 2 pills. If you're having a bad day, see what happens an extra pill does. And if it works, great, go back the next day to what you normally take. And a lot of my patients do a lot of trial and error on their own, either with my guidance or without my guidance, although I prefer with my guidance, because I'm not sure what's going to happen when you take a medicine. I'm not sure what's going to happen if you take an extra dose of medicine. But yes, the short answer is I do have patients take extra medicine when they need it, cut it back when they don't need it. And there is a lot of flexibility to me in my patients when we're dealing with the medicines. My goal is not to just ramp up your medicine. Oh, you need a little bit more here, take more, take more, take more, take more. Even though a lot of my patients are like, man, every time I come see you, you give me another medicine. That's not my goal. It happens, but it's not my goal. But I do think that if you're having a bad day and a little bit more medicine will help you get through that day, I'm not against that idea. And yes, if you do that once or 2 days in a row, but then you get out of whatever it is situation that you're in, go back to taking what you normally take. Again, I give my patients a lot of leeway with the medications fairly frequently until they abuse it. And then I tell them they're not allowed to do that anymore. But that is a conversation you should have with whoever's taking care of you, because this is not a I'm going to tell you what to do and you're going to do it kind of game. That quote unquote paternalistic medicine is no longer accepted. This is not how medicine works anymore. That is the old way medicine worked, where you went to the doctor, they told you what to do, and you did it. I don't know what that's like. My patients never listen to me. But now it is much more, how can I work with you to determine what is the best plan for you to help you do all the things you want to do and stay as well as possible, as long as possible, preferably on as little medicine as possible. That's always the game plan in my office. And so, coming back to the question, I wouldn't be against you taking a couple of extra doses when you're frozen or when you're having a bad off time or when you're having a bad day. And when you're not having those times, you go back to what your normal dosage is. But again, that is something you want to talk about and make sure your doctor is okay with, because I mean, not that, again, not that you want your doctor to get mad at you or yell at you or that that's the end result, but you want to make sure everybody has an idea of what's going on. So why does carbidopa cause nausea and does it go away? It's actually the levodopa that causes nausea. It's actually dopamine that causes nausea, believe it or not. So carbidopa, levodopa is a combo pill for a reason. And this goes back to the history of cinnamon. So initially we tried feeding people dopamine. It didn't work. It didn't get from the stomach to the brain. Then we found that levodopa does cross the blood-brain barrier, but it also makes people horrifically sick because it gets converted into dopamine in your stomach and in your peripheral blood, not in the brain, which is where you want it to. The carbidopa prevents that conversion from happening in your stomach and your peripheral blood system, and it does it when it gets to the brain. That's why you can use a lot lower dosages of it. And so the carbidopa is actually helping the nausea, but I get the idea. You're talking about the medicine in general. But that's why, it's because dopamine itself outside of your brain causes a lot of nausea. And when levodopa gets converted into dopamine outside of the brain, that's how you get dopamine there, and that causes a lot of nausea. The second part of your question is actually much more complicated. Does it ever go away? And that is variable. So some people, yes, they get used to it. Some people, if they've been on carbidopa, levodopa long enough, initially maybe it makes them a little sick, but as they get used to it or as they develop a tolerance to it, it doesn't, and they can take it just fine. Some people don't. Some people take it, it makes them horrifically sick, and no matter how many times they try it, it still makes them sick. Um, there are things you can do. So taking it with food tends to help with that, although again, protein in particular, but food in general does interfere with the absorption of levodopa, which could make it less effective. So just be aware of that. But it also, because probably for the same reason it makes it less effective, it makes it less side effect producing or nausea producing. Other things we can do is actually add extra carbidopa, again, extra of the part of the medicine that prevents that peripheral conversion to dopamine, which we think is what causes the nausea, or switching to different versions or different medicines. Again, there are ways we can work on it. So again, some people do get used to the nausea that comes from carbidopa, levodopa. Some people just don't. And I don't know that I am able to predict just by looking at you what you're going to do. The hard part is when you don't, and I have patients like this, when you don't tolerate any version of carbidopa, levodopa because of nausea, that takes away the best drug I have. Levodopa is still the gold standard medicine that I have. Exercise is the best medicine, but levodopa is the gold standard medication. And I do have some patients that just cannot tolerate any version of it, and that really does put us a little bit behind the eight ball. Not to say we can't work around that. I do. There are other things we can try, but it definitely hamstrings us a little bit in terms of our treatment strategies. I did mention ultrasound earlier as a possible next step after medications become less effective. Can I elaborate on ultrasound? Sure. So there's actually two things I want to mention about ultrasound. So there is an approved treatment using ultrasound, which is high frequency ultrasound ablation, which is the newest technology on an old idea. So we learned a long time ago that if we put a hole in your brain, we can stop mainly tremors, but maybe some of the other symptoms as well. Michael J. Fox, I believe, had this done the old-fashioned way where you drill a hole in somebody's skull, you put a probe down. And I only mention this because I'm pretty sure he talked about it in one of his books. I do not know Michael J. Fox. He is not my patient. I couldn't talk about him anyway if I did. So this is how I know this. And so he had the old procedure where he had a hole put in his brain. I think it worked a little bit, but not great. Nowadays, they can do it with ultrasound. And so they can put you in an MRI and they can beam externally ultrasound waves to focus in a certain area of the brain and burn a hole in it. And we can see it under MRI guide to make sure we're in the right spot, we're heating up the right tissue, we're burning the right area. And that can help with tremor. It is currently approved for tremor predominant Parkinsonism and essential tremor. I like it for essential tremor much more than I like it for Parkinson's disease. This is my own preference. Take it with a grain of salt. I do worry that it doesn't necessarily impact the other symptoms of Parkinson's disease, i.e., the non tremor symptoms of Parkinson's disease, as much, and maybe not as good as DBS does, which is why, if we're going to talk about invasive things, I'm going to be more pro DBS than ultrasound ablation for Parkinson's disease. Maybe not for essential tremor or other things, but for Parkinson's disease. And so just keep that in mind. But ultrasound is approved to put a lesion in the brain to help control mainly the tremors of Parkinson's disease. Maybe one of the reasons why I'm not partial to it is I can't do it here at Allegheny. I do believe UPMC just got one, and they are now up and running as of a couple of months ago, I think. So that at least puts it in Pittsburgh, because historically I've had to send my patients down to WVU or up to Cleveland Clinic, which again, I'm not against doing. They all do a great job of this. But I think I will feel more comfortable with it or be more confident in it myself when I have much easier access to it. Plus, I've had a lot of experience with deep brain stimulation over the past 15 years I've been doing this or been here. So that's probably why I'm partial to it. Again, that is my opinion. That is not proven or fact. Take it for what it's worth. But that's the approved thing for ultrasound at the moment. There is also another use of ultrasound that is still in research, which they were doing mainly down at WVU, believe it or not, where they were trying to open the blood-brain barrier by systematically or timing ultrasound with delivery of medicines peripherally. So the blood-brain barrier, for those of you who don't know, is basically a very tight cell junction that does not allow a lot of the things that are floating around in your blood and your peripheral nervous system, including dopamine, to get from your blood into the central nervous system, i.e., the brain and spinal cord. This is a very important thing to protect your central nervous system from peripheral things, but it also protects your central nervous system from medications or things that we want to get there. And so they are looking at opening up this blood-brain barrier by pulsing ultrasound and then timing the delivery of the medicine to go through at exactly that time. That's still in research. They're looking at it as a delivery mechanism of medications or finding ways to get to the brain a little bit easier, but you will hear about that in Parkinson's disease as well. They're probably using ultrasound for a lot of other things, but those are the two that I know the most about. The one that's approved is really the ablation. And I will tell you more about that once I get more experience with it. But for now, that's kind of the long and short of it. So I will stop there because that's the last question and it's 5:47. So Casey, I will pass it back to you.
Thank you, Dr. Licklider. We will be joining everyone again for the Talk with the Doc in September, on September 4th at 4:45 p.m. Thank you, Karen. This is always recorded on our YouTube channel, and please consider some of the upcoming webinars and sign up for Step Forward. Thank you, everyone, for attending. Enjoy your August. Bye.